All right, good morning. It is Megan Knight here from Good Morning Maryland. We're doing our Facebook Live discussion today talking about breast cancer. Of course, October is Breast Cancer Awareness Month, but really, this is something that we should be talking about all year long. So, throughout the discussion, you can leave us your questions in the comment section, and we will get to them as we are chatting with Dr. Sarah Fogarty, who is the director of the Breast Cancer Center at GBMC. Good morning, doctor. Thank you so much for being with us.
Good morning. Thank you so much for having me.
Of course. So maybe before we dive into some of the questions, if you want to just give me a little bit of background about your role there at the Breast Cancer Center at GBMC and maybe just some of the services that you offer there.
Absolutely. So I am the director of the center and have been since January of 2020. I've been here for about 8.5 years as a breast surgeon. Um, we have a very robust multidisciplinary cancer center. When I think about GBMC, I think about people should come here to get treated for their cancer. We have a wonderful oncology department, a fantastic um, oncology support center. We have an amazing genetics team. We do radiation on site. We have a plastic surgeon in our office with us 3 days a week. We are really a one-stop shop, and it's really makes it easy for patients to navigate all of their treatment, which can be very overwhelming.
Absolutely. Yeah, I think that really is key to have that all under one roof, so to speak. So then that way the patients know that everybody that they need in this process, in this journey, which is already difficult as is, they're all right there guiding them every step of the way. So I always like to ask when we talk about these more prevalent diseases like breast cancer, it always seems like every few years, 10 years or so, the guidelines are changing, the recommendations are changing. So, Dr. Fogarty, if you could just kind of bring us up to speed in terms of the guidelines for breast cancer, when we need to be getting our mammograms, how often should we be doing self-exams, all that good stuff.
Sure. I mean, that's a huge amount of information with breast cancer, especially. There are so many developments that rapidly come through. Things that we did 3 years ago are not always what we do now, just because there's so much research and so much money that is poured into it, which is great. So with breast cancer, I'm part of the surgical team, of course, the medical oncology and radiation team. There's been a lot of advances with drug therapies and radiation therapies, more so than surgical therapies. Really, there was an article that just came out about surgery saying that breast conservation and radiation may actually have better survival rates than mastectomy, which is, a complete 180 of what we used to do, a long time ago, 70, 80 years, where that was the only option for surgery. So luckily, as we keep enrolling patients in clinical trials, which are so important to learn more and understand, we can really start limiting these therapies. There's been a huge push in really downstaging patients with chemotherapy first to allow for smaller surgeries. We are having a lot more complete pathologic responses with patients that undergo therapies first before surgery, meaning all of their tumor and cancer cells are killed with the therapies they get preoperatively. And that's, a wonderful thing to have and really improves prognosis. So, it's a huge topic to kind of delve into quickly, but there are continually, everything is advancing, and really the idea of patients undergoing less therapies with still good results is where this is all going, which is great.
Yeah, that is absolutely great news to hear. So many advances, as you mentioned, that are being made in research and development, and those clinical trials certainly are a big thing as well. We know that we're supposed to get our mammograms. Any new advances in terms of that? I've heard about 3D mammograms. Is that different than maybe the traditional one that we're used to seeing and getting?
Yeah, so 3D mammograms have been around for a little while now, and that's really the mainstay of screening, especially for our cancer patients going ahead. 3D just makes it easier to see through denser breast tissue, which is very normal and common, especially in younger premenopausal women. So 2D mammograms was the original way where they take two views of each breast. They still do that with the 3D. They still compress you, which a lot of women will ask, oh, do I not have to get squished, which is, the uncomfortable part of mammograms. But the 3D actually has a camera that arcs around the breast when it's on the plates being compressed, and it helps us scroll through the tissue to kind of cut through it and hopefully find things that we would have missed on regular 2D. Um, it's very important for young women for screening. It's very important in dense tissue, and it's really what we use to screen most patients these days. The American Society of Breast Surgeons screening recommendations at this point is to start mammograms annually at the age of 40. Um, when to stop mammogram is still a little controversial, and really there isn't any clear data. But basically, if you're in very good shape and have at least 10 more years of lifespan, screening mammogram may still be appropriate. So a lot of women will say, oh, at 75, I should stop, or 80, should I stop? It's hard to know. And it's really a conversation to have with your doctors when screening should stop. But 40 annually is the American Society of Breast Surgeons recommendations at this time. That screening mammogram recommendations have changed. They vary from group to group because, as part of the American College of Surgeons, as an accredited through the NAPBC, we follow the American Society of Breast Surgeons recommendations.
Gotcha. So if you have a history of breast cancer in your family, do you recommend starting it earlier, or is 40 still kind of the benchmark?
So that depends. We've been doing a lot of high risk assessments for patients with family histories. Women that come in saying, well, my mother and my aunt and my grandmother all had breast cancer at these ages. Should they start screening earlier? 35 may be the recommendation, but that is definitely a individualized basis and should be discussed with your OBGYN. Maybe if you really have a significant family history, you should see genetic counselors. Your family should have had genetic testing potentially. And we do high risk assessments to evaluate patients' risk through computer models to see if that's appropriate or not. So yes, potentially. It's something to bring up with your primary doctors for sure.
All right, very good. I just want to give a quick shout out to Audrey, who is joining in on our conversation. She writes that she rang the bell almost 1 year ago at GBMC, and she tries to sneak a visit to you guys every now and then. She says she loves all the staff there.
Oh, that's so nice. Thank you, Audrey. That's great.
Yeah, good to hear those success stories. Absolutely.
Yes.
So anyone who's considered to be high risk for breast cancer, does that kind of vary person by person, or can we generalize that in some way?
No, it varies, but what we take into account is the patient's, of course, family history. Any women in the family with young premenopausal breast or ovarian cancer, we always look at. Your gynecologic history, how old you were when you first got your period, how long it was till you underwent menopause, did you have any children, any hormone replacement? These are all things we look at. It does take into account breast density as well, which can increase risk. And that's really, we use these models, a computer model, to enter in data to see what the risk level is compared to the population of your same age group.
Gotcha. Anything that we can do to reduce our chances of getting breast cancer? People always like to know, should I be eating healthier, exercising more? What can I do to decrease my chances?
That's exactly right. All of that. And that's not just for breast cancer. That's just for life in general. Exercise is extremely important. The recommendations are 150 minutes a week of strenuous, sweating exercise. So 30 minutes, 5 days a week minimum. Which I know a lot of people don't do. Eating well, having a ideal body weight, increased BMI increases risk of all cancers and heart disease, which are the #1 killers in the country. Limiting alcohol intake for breast cancer is also an important risk factor. And that's really, that's all that you can really control. You can't control aging, you can't control family history and those risks, but diet, exercise, and alcohol intake are things you can control. So that's absolutely, what we try to recommend for patients who are either at higher risk, any patient that has concerns, or any patient that has had breast cancer to help decrease risk of recurrence.
Very good. Yeah, all good advice right there. Just a reminder, if you would like to join in on the conversation, if you have any questions for Dr. Fogarty about breast cancer, treatment options, when to get your mammogram, all that good stuff, please leave your question in the comment section. Okay, let's talk about maybe non-cancerous cysts or lumps. Maybe I do a self-exam. I feel something that's a little off. I go see my doctor. They say, oh, we look at it, it's non-cancerous. Do I still have a chance of perhaps developing breast cancer later down the road, even if that lump is not cancerous?
Yeah, I mean, anytime we have a patient come in with a lump, and some patients see their GYNs and primary cares first, some patients will come see us. I always recommend imaging to evaluate it to make sure we're not missing something. Cysts are very common. Benign, simple cysts are not for an increased risk of breast cancer. It really depends on what it looks like on imaging. Sometimes we will follow up with short-term imaging, 6 months later to double check. But most simple cysts are very benign and nothing to worry about. They can come and go. But it's always good to get everything checked out. If it's new for you, talk to your doctor. Maybe, an ultrasound and or a mammogram can potentially be very helpful there.
Okay. One question we had sent in, someone said, if I have been told that I have cystic breasts, should I see a breast surgeon for follow-up? And if yes, how often should I see the breast surgeon?
I think that depends. You don't have to see a breast surgeon. It depends maybe on other risk factors too. Do you have a family history? Are you at high risk? And is your imaging difficult to follow? I think, if we also depends on how comfortable the GYN or the primary care is with following patients like that. It really just depends on the individual and all their other risk factors. I wouldn't say necessarily you have to see a breast surgeon for that. It just depends on the situation. Sometimes just having an evaluation one time to go through the imaging, and then obviously if something new pops up, you're plugged into the system at least. But I think it's very reasonable to at least discuss with your primary care and GYN first and see what they recommend.
All right, very good. In terms of treatment, you did touch on this a little bit earlier in the conversation, but maybe if someone's just joining us, we can kind of revisit it. When somebody comes to the breast care center at GBMC, they've been diagnosed, how do you determine what the best course of treatment is for that person?
Well, it's very individualized. It really depends on a lot of factors about the type of cancer they're presenting with, what the imaging shows, how the patient's presenting, and really specific to what we call prognostic factors or what type of cancer we're dealing with. There's a lot of different types of breast cancer, and that makes a huge difference in what we recommend for treatment. I definitely have women come in saying, well, my aunt had chemo and double mastectomies and radiation and more chemo, and you're telling me I need a lumpectomy and a pill. How is that possible? It really varies. So that's, it's a very individualized approach that we have. Of course, every diagnosis, we go through the pathology with patients in detail and discuss why we recommend what we recommend. But there's, a lot of options and a lot of right ways to do it. And it really varies. So it's hard to, I guess, answer that right off the cuff, but
Sure.
It is definitely a long, in-depth discussion that we have with patients to make those plans and recommendations.
Well, all the more reason why to come to the center and to
Yes.
talk with the team there, because
Yes.
you get a lot of great different opinions to really, like you said, personalize, make your plan fit you and you alone.
Correct.
Another question, talking about the breast care center, is it going to be moving at all when the construction of the Promise project is completed? And can you give us any hints as to what we might see in the new center?
Yeah, so it's very exciting. We are moving when the cancer center opens in a couple years, which will be great for our center. We'll have a lot more space. I think it'll be absolutely beautiful and a really nice area as we plan this for patients to be seen with their imaging. The imaging department and our department are intertwined right now and will continue to be that way, which is just imperative for patient care and getting things done quickly for patients with imaging and biopsies. So we'll be in the same space like we are now. And it's going to be a beautiful, brand new building. I'm very excited about it. I think it'll be really a great place to have all of the disciplines under one roof. So it'll be very easy to navigate between us, medical oncology, genetics, radiation. It'll be a really easy place to get in and out of and have everything under one roof. So I'm really excited about it.
Yeah, I was gonna say that sounds really, really awesome, really exciting, especially for not just for the doctors, but really more importantly for the patients.
Yes, it
Yeah.
will be very easy. I know right now with the construction, it can be very frustrating trying to get into places on campus, and that will be so much better when this is finished, and it'll be really a wonderful place for patients to come in and out of easily. The last thing that people need when they're going through all of this is extra stress with trying to park and get into appointments on time. So it will be really a great place, and we're going to have, a much bigger space with radiology and ourselves together, to be able to fit everybody comfortably, which will be great.
That'll be awesome. Well, we
Yeah.
are looking forward to that. Maybe as we start to wrap up here, Dr. Fogarty, any new treatments out there? You did touch a little bit on new research, but if you maybe wanted to share anything new that's out there that might be good for us to know, whether we have breast cancer, don't have breast cancer, know someone who has it.
Again, a lot of new advances in medications and chemotherapy regimens, and really exciting treatments for hard cancers to deal with, which is great. I think that breast conservation is something we really strive for, and is really being shown to be the best treatment options. It's not always possible. Again, very individualized. Some patients, that's not an option, but we really try to strive for that. We do a lot of lumpectomies with reduction surgery for women that have wanted reductions previously. And that's sort of a silver lining. If we're going to have surgery anyway, we can get that done at the same time. And a lot of women just love that procedure. And so, surgically, not too many new advances really, but something that we've been striving for and have been accomplishing the last few years is really breast conservation. And that's, being shown to be better options potentially. So
Sure, both medically, and I would have to imagine for the women who are going through it too,
yeah,
their mental, emotional
yes,
well-being probably is served greatly by that.
yes, it's true.
Very good. All right, well, Dr. Fogarty, if there's any people are watching, they'd like more information about you and your team there at the Breast Care Center at GBMC, how can we get in touch with you?
Sure, absolutely. Our website at GBMC, just search breast care, and you'll have all the information about me and the whole team and how to call for an appointment, 443-849-2600. And you can also log on, and there's other phone numbers too on the website to call for appointments. So feel free to look us up and call if you need anything.
Very good. All right, Dr. Fogarty, thank you so much for joining us this morning. Lots of great information. Again, Breast Cancer Awareness Month in October, but always good to talk about these things year round. So thank you so much.
Yeah, thank you so much for having me. I appreciate it.